most things, but I think he had to leave. Yeah, so. Okay, well, go ahead and get started. Hello, everyone. My name is Michael Jarvis. I'm the editor-in-chief of Pharmacology Research and Perspectives, and it's my distinct honor to introduce our closing plenary speaker. Jane Davies is a professor of pediatric respirology and experimental medicine at the National Heart and Lung Institute at Imperial College London. She's also an honorary consultant in pediatric respiratory medicine at the Royal Brompton and Harefield NHS Foundation Trust. Professor Davies is an eminent researcher in the clinical treatment of CF, and she wears many, many hats, not the least of which is she is the clinical lead and strategic group member of the UK Cystic Fibrosis Gene Therapy Consortium, and she's a leading scientist in the Core Lung Clearance Index facility at the European Cystic Fibrosis Society Clinical Trials Network. Professor Davies and her colleagues have really set a standard for the translational research and precision medicine in terms of developing CFTR modulators for cystic fibrosis patients. These medications have had a phenomenal impact on a vast majority of CF patients, and it's my delight to welcome her to the stage. Thank you, Jane.
Thank you very much, Mike, and thank you so much for the invitation, and welcome everybody. You've lasted well to get to the end of your conference. I was just telling Mike that the last time I stood on this stage was at the European CF Society Conference in 2019. That was the last CF conference we had until this year, so it's actually really, really nice to be back in Liverpool. As Mike said, I am a clinician working largely in translational research, but I have obviously got a very clinical take on the exciting topic that I've been asked to talk to you about today. I'm aware of the background of the delegates at this conference. I'm certainly not going to try and talk to you about PK or any other complex pharmacology, but we will talk a little bit about the basic science around cystic fibrosis, because I think it's important to set the scene of how these drugs are working, and then also perhaps a little bit about some of the complexities, particularly around the dosing and the drug-drug interactions that we're facing in the clinic related to the pharmacology and metabolism. So I've called this talk A New Era. This really very, very much is a new era for cystic fibrosis over the last decade or so. In terms of the drugs I'm going to talk about, I'm going to focus on those which are now licensed and in the clinic. There are a number which are coming from other commercial sponsors through clinical trials, but in the interest of time, I won't go into all of those today. So the drugs we'll talk about are made by Vertex Pharmaceuticals. I've been on some of their advisory boards, and I've been national and global leader on some of their clinical trials by way of disclosure. So for those of you who are perhaps not in the world of cystic fibrosis, I'm sure most of you are familiar from O-level biology that it's an autosomal recessively inherited condition. In the UK, the carriage rate is around 1 in 25 heterozygotes, leading to around 1 in 2,200 live births. It's now detected very early in life on newborn screening with the heel prick blood test. The cause of cystic fibrosis is a defect in an epithelial ion channel, which we called cystic fibrosis transmembrane conductance regulator, CFTR for short. And cystic fibrosis is a disease that really is manifest by multi-organ involvement. So here is the culprit, the CFTR protein. This is a normal wild-type CFTR sitting anchored in the apical epithelium of a normal epithelial cell. It's a dynamic channel when the regulatory domain, as you can see here, this is the one that didn't work very well, isn't it? The regulatory domain is this golf ball-like structure. When this is sitting out of the pore, as is shown in this picture, chloride and also bicarbonate is able to transport out onto the surface of the cell. Now, CFTR functions on hollow-lined epithelia largely. So when it is deficient in people with cystic fibrosis, we see disease in those organs. So if we start at the top here, the upper respiratory tract, sinus infections and nasal polyps. In the lungs and the conducting airways in particular, we see a loss of function of CFTR leading to reduced lung function, lung infections, inflammation, and I'll tell you why in a moment. But we also have a very useful biomarker in terms of CFTR being an important channel in the sweat duct, and that leads to high levels of salt in the sweat of people with cystic fibrosis. CFTR is absolutely critical important in the male reproductive tract, and in fact the male reproductive tract is the organ in the body that's most sensitive to any loss of function of this protein. So infertility in males is pretty much a hallmark of cystic fibrosis. And then CFTR is also present throughout many, many organs of the GI tract, but particularly in the pancreas, where it leads to failure of the exocrine pancreas, so failure of digestive enzymes coming out of the pancreas into the gut. And it is this particular organ that leads to the manifestation of failure to thrive in children in whom that diagnosis isn't made in a timely fashion. So what I'm going to show you here is just the lung. We're going to focus mostly on the lung for this talk because it's the lung disease that causes most people's clinical problems, and it is the lung disease that causes most premature death. So if you imagine these are cells lining a normal airway and a CF airway, this is the airway side, this is the blood side, this is where the CFTR protein sits when it is normal and functioning normally. And it allows small amounts of chloride out of the cell in a dynamic fashion, as I've shown you, bicarbonate also probably being important in most organs, but particularly the GI tract. But in addition, this channel has a regulatory impact on a neighbor, which means that the amount of sodium coming through the epithelial sodium channel, or ENaC, is quite tightly regulated and kept low. In contrast, in a CF cell, many CF cells produce protein that doesn't get to the place it's meant to be. And so we lose the chloride's ability to come out of the cell, but we also get loss of this inhibition of the sodium channel. We get too much sodium coming into the cell, and pretty much throughout biology, it's a truism that where sodium goes, water will follow, and that's what we see happening in the airway. The reason that's important is because the conducting airway relies on the function of these microscopic hairs or cilia to clear debris out, so to clear mucus with inhaled pollutants, with inhaled viruses or bacteria out of the airway. And these cilia need an optimum amount of water in which to function properly. There's a nice so-called low volume hypothesis which illustrates this. So this is the start of an experiment with a normal wild-type epithelia at the bottom here and a cystic fibrosis epithelia. The experimenter has put a fixed volume of green fluorescent liquid on top and then walked away for 24 hours. And when you come back, you see that this volume is well maintained in the normal airway, but the water has been drunk up by the epithelium with this CFTR defect. And the problem when we look at the cilia is that unlike these ones, which can stand up and therefore can beat in a coordinated fashion to clear the mucus and the debris, these CF ones no longer can. They're all bent over, and actually the CF surface produces too much mucus as well. So this pretty much leads to the problems with cystic fibrosis lung. This is quite a simplistic cascade, but if you consider that 2 copies of an abnormal gene lead therefore to abnormal protein, there's a number of different ways in which that protein can be abnormal, and I will tell you about that in a moment, but they all lead to the same thing. So impaired chloride and bicarbonate secretion, too much sodium and water coming in, and mucociliary clearance, which is the airway's primary defense mechanism, then fails. We get thick dehydrated mucus building up and clogging the airways and leading to mucus stasis. And we also get excessive bacterial infection and an excessive inflammatory response to that. And all of this together leads to what we term bronchiectasis, and that is an irreversible dilatation of the airways and scarring. And really, once that's happened, it's impossible to turn the clock back on that. Respiratory failure is the commonest cause of death for people with cystic fibrosis. And until this so-called new era, this was really occurring anywhere between late 20s and early 30s for a lot of our patients. What I've put here is a dotted line below which all conventional cystic fibrosis treatments were targeted. So when I was coming through cystic fibrosis middle grade medical training, and even for many years as being a consultant, every single thing that we've had to offer a patient with CF has been targeting symptoms. We didn't have anything that targeted the root cause of the disease. And this new era that we've entered now is allowing us to target the root cause in terms of the abnormality of the CFTR protein. So we're seeing for the first time these drugs that can actually, we don't have to wait for these symptoms to have occurred. We can actually correct the defect at an earlier stage. This really all very much stemmed from the discovery of the CFTR gene in 1989, you can see here. And this was a collaborative effort between 3 different groups in the States. You can see here Francis Collins and Lapchi Choi, who together pooled their resources in a way that at the time was very refreshingly uncommon, because most labs have to compete with each other in order to survive. They pooled their resources, and out came 3 papers back to back, describing and locating the gene encoding this CFTR. And it's really the learnings that have happened since then that have led to the development of these new drugs. So this is where the gene was discovered. It's on the long arm of chromosome 7. It's a really quite a long gene. It's got multiple exons in it. And described within that gene are over 2,000 different variants or mutations on various databases around the world. What we do know is that they're not equally CF causing, but you can see some of the commoner ones here. You may have heard of delta F508 or F508del, as it's now preferentially called. There's a couple of the other common ones here. What's, I think, less well known is that there are also a number of variants in introns that can lead to sufficient disturbance of protein function that they can actually also be related to disease manifestations. But of those over 2,000, the vast majority are dominated by a small handful here. So this is the prevalence of the 25 most common mutations in people with CF in 2018 in the US. It's actually really very, very similar in most of Europe as well. So you can see of chromosomes, 85% of them have this common F508del mutation. The next most common is seen in fewer than 5% of chromosomes, so really very, very much dominating the field. And then there's a few that are relatively common. This one will crop up again as we're talking. And then things become vanishingly small very quickly. I've heard quoted that of the 2,000 variants described, 1,000 of them exist in fewer than 5 people in the world. So you can begin to understand the complexity. It's a single gene disorder, but within that gene, there's so many different reasons for things going wrong. I'm going to describe some common classes of what can go wrong. So what we've got here on the left is a cross-section through the cell. Here's the nucleus, the endoplasmic reticulum, and the Golgi, and here's the surface of the cell. And in a normal, healthy person, me, for example, I know I don't have any of these gene variants. I have 2 normal copies of CFTR on my chromosome 7. That gets read out by the mRNA and translated into protein. The protein then passes up through these intracellular organelles, and it acquires its sugars in a glycosylation and folding process, which allow it to process up to the cell surface and to sit here and function in that way I described to you at the very beginning. Now, in people with CFTR mutations, there are several different types of things that can go wrong. The first of these is right down here at this stage of mRNA and translation, and that leads to no CFTR being made at all. So these are nonsense mutations where somewhere early in the gene, there's a mutation that leads an amino acid code to actually read stop instead. Here we have the F508del, the commonest of the mutations, which are sometimes termed class 2. And this mutation leads to full-length protein, and it does get made, but it doesn't fold up and get glycosylated properly because of a deletion in a particular area that's important for disulfide bond formation. So instead of this getting its sugars and trafficking up to the cell surface, it gets degraded down into its amino acids and recycled through the cell. So these are sometimes called trafficking defects or misfolding defects. Now, all of the other defects do lead to protein that reaches the cell surface, but there's something else wrong with it. this is one of the commonest things that goes wrong, is that it sits at the cell surface, but there's something wrong with the machinery inside the cell. And when it's told to open by the intracellular instructions, it can't do so. For that reason, these are called gating mutations. And you may have noticed the G551D that I said was going to come up. That is a very common gating mutation, sometimes called a Celtic mutation. It's really common in people of Scottish, Irish, Welsh origin. And actually, it was this mutation that led to the UK and parts of Northern Europe getting such a big role in the initial studies of the first molecule that came through, because we have a much higher prevalence of that mutation than is seen in parts of the States where the company was based. There are other types of mutations which can lead to abnormal conductance. So you can see here, this looks pretty normal, but actually there's something wrong with the pore. So when it opens, not as much chloride and bicarbonate comes out as it should. And we can also have mutations that lead to not enough CFTR. You might imagine that these two might not be quite so severe as those other mutations, which were a little bit more all or nothing, and you would be right. So sometimes together, this type of mutation is called residual function. CFTR is still working a bit, but it's not working enough to completely protect the person from disease. These things, in contrast, are usually called minimal function. So there's very, very little protein function coming off those. And I do have some slides later where you will see MF for minimal function and RF for residual function. So the understanding of these groups really led us to be able to categorize these mutations into 3 different groups depending on the possibility of modulator drugs being able to improve the function of CFTR. And the first of these, for those that don't make any CFTR, this is an absolute requirement for so-called CFTR modulators to work on. So if there's no CFTR protein at all in the nonsense mutations, modulators are not going to work for them. There may be other approaches that will work, and we don't have time to go into them today. But for example, ribosomal read-through agents or mRNA stabilizers, or even gene or mRNA therapies may work for those patients. None of them at the moment are in the clinic. None of them are licensed, but there are some in clinical trials. So when we're talking about the concept of modulators, what we're talking about is 2 different types of modulator. The first is correctors. This is a molecule which allows the misfolded CFTR to fold up correctly and get to the cell surface. And for that reason, they're called correctors, and there are several of them that have been through trials and are now licensed. They have been found in the early stages not to be sufficiently potent on their own, so they have been used in combination with another type of modulator called a potentiator, which actually kicks that normally located protein into overdrive. So it makes the channel open more frequently than it would otherwise. So these are the 2 terms that you need to really keep in mind, correctors and potentiators. And then, of course, there are these channels where they are already in the right place. And as you might imagine, potentiators on their own could work on them. And that is, in fact, where the first of these agents came from through medicinal chemistry into clinical trials. So first of all, just to show you, all of these are small molecules. They're all administered orally. They are bioavailable through the gut, but they have to be administered with fat-containing food. And for most people with cystic fibrosis, that means also the pancreatic enzyme supplements that they take with any fat-containing food. So that is potentially one of the limitations of their current activity. So the potentiator that is in the clinic at the moment is called ivacaftor. I think these structures might mean a little more to you than they do to me. There are 2 first-generation correctors which have come through clinics into license, lumacaftor and tezacaftor, but both of them were used in combination with ivacaftor in a dual-agent sort of approach. And then there's a next-generation corrector called elexacaftor, the structure of which is there, which has been used in combination as a triple with tezacaftor and with ivacaftor. There are a number of other molecules coming through clinical trials, both by Vertex and also by a number of other companies, but they're not yet to the stage where they have been applied for license and are being used in the clinic. Just for interest, there is also a molecule with a deuterated version of ivacaftor, which is coming through some clinical trials at the moment, the purpose of which is to try and cut down. This at the moment requires twice daily dosing, whereas everything else requires once daily. So deuteration allows this molecule to be given in a once daily form and would allow, for example, the triple molecule only to have to give them once daily. So it really was the understanding of the protein function and the genetics behind it that led to several programs, one of which ultimately came to fruition and conducted a very, very thorough and time-consuming, high-throughput screening of CF cells in the laboratory and their ability to secrete chloride upon chemical stimulation. And then large numbers of chemical hits were tested against them. And once those hits were identified, medicinal chemistry optimized them, and that led to the first of these drugs. So you'll recall this is a potentiator agent that was first developed by Vertex. So what the potentiator is doing in this context is acting as a single agent. It's going to a protein that's correctly located but doesn't open, and therefore the chloride and bicarbonate can't leave the cell. It's binding to it, and it's creating a conformational change which allows that channel to open. Before we go on to some of the trial data, I thought it might be useful for this audience to talk about how we measure clinical success, because it's obviously a little more difficult than looking in a Petri dish and seeing a color change when chloride comes out. Lung function is one of the main ways in which we test the efficacy of these drugs in clinical trials. This is a forced maneuver where a child or adult blows into a machine as hard and as long as they can. We get the expired volume in the first second, which is called the FEV1, and we get the total expired volume, forced vital capacity. And those are abnormal in many adults with cystic fibrosis, and therefore a very, very useful primary outcome in clinical trials. Also because they're associated with mortality, basically. They're a reasonable link with when somebody requires a lung transplant. The limitation is that they tend to be normal in most children and in many adolescents and even some adults. They're not very sensitive to early lung disease. So as Mike mentioned earlier, we have been developing more sensitive lung function techniques, and the lung clearance index is one of those I'll mention briefly later. Symptoms are important, so we have validated quality of life questionnaires I'll show you some data from. Symptoms in terms of pulmonary exacerbations, so flare-ups that take people into hospital and sort of take them out of school or work for a couple of weeks. Bacterial infections. I mentioned that we have this nice pharmacodynamic readout of sweat chloride, and that's been a really important part of the trials, but particularly important when we've been trying to go from good proof of clinical efficacy in older populations down to younger populations with smaller trials. The regulatory authorities allowing us to use sweat chloride as a PD readout has been very, very useful. Pancreatic exocrine function is something I never expected that we would find useful as a trial outcome. I was raised on the belief that you were born with pancreatic exocrine dysfunction and it would never come back, it was irreversible. In fact, these drugs have shown us that if you start them early enough in life, you can get some reversibility of that. Some of the longer studies are looking at complications such as CF-related diabetes, and then imaging, for example, with CT scan or MRI scans is less common as part of clinical trials, but being used more commonly in real-life assessments of these drugs. So this was the first phase 3 trial of ivacaftor that came out. Even those of us who I think were involved in the trials were really astounded by the magnitude of the impact here. I'm just going to show you first of all the sweat chloride results. Of course, this is not clinically meaningful to a person, but it is very, very meaningful in terms of reading out that that drug is doing what you wanted it to do. Here's the placebo group, all of whom maintain their very high sweat chloride of around 100 millimoles. Here's the diagnostic threshold for cystic fibrosis, which is 60 millimoles. And the entire group means were below that diagnostic threshold almost as soon as they were measured. So this trial first measured it at 15 days, but other trials have actually looked at day 3 and beyond, and this happens very, very quickly. So the drug is well absorbed, it does what we want it to do, it makes the CFTR work properly, and we get a drop in that sweat chloride. This was the improvement in FEV1, so lung function. I don't expect that graph to mean much to any of you. But for those of us who are working in cystic fibrosis at this time, we were quite pleased if we had a new drug that led to 3 or 4% improvement. And here we were seeing an 11% improvement from baseline in that, and that was maintained during the 1-year study period. This was exacerbations, so fewer hospitalizations and admissions, and then also improvements in body mass index and weight. So really very, very promising. Of course, shortish-term outcomes, and for a period of a year, very, very nice to see. What most people would really care about is the longer-term outcomes. And luckily, we've had ivacaftor around as a very potent monotherapy for long enough that we can begin to look at those now. So here are just some long-term data from a combination of US and UK registries that were published jointly. And here's one of those outcomes, exacerbations. So imagine you're just about okay with your cystic fibrosis. You might spend an hour or 2 hours a day keeping yourself well with all your treatments, and then suddenly your lung function drops, your symptoms go off, you feel exhausted, a little bit COVID-like, actually, some people describe exacerbations as, and you end up cancelling all your plans for the next few weeks, going into hospital, having a drip, going on IV antibiotics, probably getting diarrhea as a result of that. These are a really major issue for people's quality of life, but more importantly, people who have a lot of exacerbations have a more rapid rate of loss of lung health and a more quick deterioration to the point of either lung transplant or early death. So they really are a major deal. What this study did was it looked at patients who were able to get ivacaftor versus those who were not, who were propensity matched, so it was a carefully done study. They looked at them in the baseline year before ivacaftor became available. So here's the ivacaftor group, their frequency of exacerbations, and here's their counterparts. They're pretty similar. If anything, these are a bit higher. And from every year after ivacaftor was available, there was a gap, and that gap actually appeared to be slightly widening. So the people who were on ivacaftor had fewer exacerbations, and we saw exactly the same thing mirrored in the UK data. Really encouraging, real translation of cost savings in terms of these are very, very expensive drugs, and so some of that expense was being offset by a decrease in admissions. Pseudomonas is a bacterial infection that is very dear to my heart. I have a lab which is studying mechanisms of infection of this. It's associated with worst outcomes in people with CF. And similarly, at baseline, there was not much difference. Ivacaftor group perhaps a little higher, and fewer of them with that bacterial infection in both of these groups afterwards. And then probably the one that's the most important is the rate of loss of lung function based on the FEV1. And so you can see here the ivacaftor group starting slightly lower, improving a lot, but then actually flattening in terms of their slope of decline here. So hitting that threshold for having lost sufficient lung health that you actually need a lung transplant at a much later date. And that did translate into improvements in survival and need for transplantation. All of this is about ivacaftor at the moment, single agent potentiator, and the big problem with that is that not many people with CF have the right types of mutation to benefit for this. So it's about somewhere in the region of 5 to 6% of people have a mutation that ivacaftor on its own will be suitable for. What actually the holy grail is this chap here, F508del, because that's what the vast majority of people in the world have as a cause for their cystic fibrosis, either in 2 copies, which is really common, about 45 to 50% of people in the world are homozygous for that mutation, but the heterozygotes are very common as well. So it was quite quickly realized this was where attention needed to go in terms of the next stage. So just to zoom in a little bit on what's happening here, this is the F508del. It gets degraded in the proteasome because it is misfolded and it's unable to traffic up to the cell surface. So what correctors are doing is they're harnessing that misfolding step, binding onto the protein, correcting to some degree the misfolding and letting it get up to the cell surface. But as I mentioned earlier, the early drugs that were tested, the first generation correctors, they were not strong enough on their own to be useful enough. And when they were used in combinations with potentiators, they had a lot more clinical utility. Here's the first of those. The first generation corrector, lumacaftor, partnered with ivacaftor. This was then marketed as Orkambi, so many of you might be familiar with that. These are data from the first large phase 3 trial, placebo patients, lung function remaining flat, and about a 3% improvement in patients taking this dual combination. And then here was the rollover. Definite signal, statistically significant in a very large trial, but compared with what we knew we could get, because we'd just seen it with ivacaftor, perhaps a little bit disappointing. What in that trial was maybe more impactful was the impact on hospitalization. So quite a lot fewer admissions to hospital and events leading to IV antibiotic treatments. So these drugs were certainly useful, but I think we all thought we could do better. The other first generation corrector was very similarly effective. It was slightly better tolerated by people. And I think, to summarize, they both had an early impact on the FEV1, but it was really quite modest. So the attention really then turned to the triple combinations and thinking about whether we couldn't achieve more ivacaftor-like impact by getting better correctors. And really, the reason triple combinations are needed is because CFTR misfolding is a very, very complex abnormality. It's not a single misfolding defect that you could apply a molecule to and it would suddenly be fine. It's a complex misfolding that's misfolded in more than one place. And so the first and second generation correctors differ in terms of where they bind to the defective protein and therefore how they correct misfolding. The name of the new corrector is elexacaftor, and here we see some data from two different assays preclinically on how this triple molecule performs. The first that we might look at, first of all, just to anchor you, this is cells from a patient who have a single copy of F508del and a minimal function on the other allele. The important thing about that minimal function is it was shown in the labs not to respond to these drugs. So any impact that was coming off this triple therapy was going to come off the single allele of F508del. And then these are cells from patients with two copies with 508del. What we're looking at here on this blot is band B is immature CFTR protein. And when the protein gets mature, correctly folded and glycosylated, we begin to see this band C appearing. So what you can see is in the presence of the elexacaftor, we begin to see much, much more band C appearing than we can get with either tezacaftor or ivacaftor. So that's good. The protein's there, it's glycosylated. Does it actually work? If you go over to this side here, we can look at actually chloride transport measured in ion channel assays. And you can see that increasing amounts of chloride transport in both types of these cells in the presence of the triple combination, as you can see here with these three. So there were a number of different second-generation correctors which were looked at, many of them similarly effective, and some of them went actually into clinical trials as well. But elexacaftor was the one that's ultimately made it through those clinical trials and has now been licensed. And I'll show you some of the trial data. Here's, first of all, the patients who have only a single allele of F508del. And absolutely astonishingly, a sort of 13% improvement in their lung function very rapidly. Until this time point, this group of patients had no other modulators available for them. The dual modulators weren't sufficiently powerful, so this was a placebo-controlled trial for a period of 6 months, and really you can see that terribly clearly, and you can really clearly see the impact on hospitalizations. The trial that happened in people who have two copies of 508del, they were already eligible for dual modulators. And so that trial wasn't ethical to compare them against a placebo. They compared them against the best of those dual modulators, which was the tezacaftor, ivacaftor, which of course is two molecules in the triple anyway. So all you're seeing with this line is the additional impact on lung function of elexacaftor, which was an over 10% uplift in that. So really very, very extraordinarily powerful in terms of lung function. Similar sorts of impacts on sweat chloride, This is the CFQR related, so this is the quality of life specific for cystic fibrosis, way above the minimal clinically important difference and improvements in BMI. And these second two outcome measures were also used in the homozygous delta F508 group. These data, if you would like to look at them in more detail, were published back-to-back in Lancet Respiratory and the New England Journal. And since then, there have actually been a number of other studies of this triple molecule, which I haven't got time to go into in enormous detail, but really pretty much all looking very, very powerful and leading to license now for what we in the UK call Kaftrio, what in the US is called Trikafta. Don't ask me why. You probably all know why drugs have different names in different parts of the world. I can't figure it out myself. So could we do even better than this? I mean, I'm always being asked, can we maximize the impact? The data I've just shown you were from trials in patients 12 years and above, so adolescents and adults. And I think there are a number of ways in which we could potentially do better. One of those is to start early. And the reason being that babies with cystic fibrosis are born with normal lungs. They acquire their lung abnormality during their childhood and into adolescence. So if we could start correcting the way that this abnormal protein functions before they've got that lung disease, then I think that would be is likely to translate into much, much better long-term outcomes. It's a great idea, but the trials in that age group are very, very hard to conclude that you've made a difference. The reason being that actually we look after children pretty well at the moment, and spirometry, as I told you, is not very sensitive. So this is where lung clearance index comes in. Just as an anchor, this is to show you a hyperpolarized magnetic resonance image of somebody with completely normal spirometry, normal FEV1, and you can see I wouldn't want those lungs. I'm sure nobody else in the room really would either. So it's not picking up this defect. So what we do with LCI is it's a multi-breath washout test. It's tidal breathing. Children don't need to make much of an effort with it. And it picks up a signal from the entire airway tree. And we can watch the tracer gas, which in this case is nitrogen, as it washes out of the lungs. And in people with healthy lungs, that washes out quite quickly. And in people with patchy lung disease, some areas wash out quickly and some areas wash out very slowly because the airways are narrowed. And that leads to a much, much longer washout time. And we can calculate a thing called lung clearance index from that. And Mike mentioned that we'd set up a core facility for Europe, which has allowed standardization and has meant that some of the commercial companies who are testing their trials have confidence enough to run these trials through the core facilities. And we're doing this in collaboration with both Sick Kids in Toronto and Westmead in Australia. So it's a properly global endeavor. And there have been now probably 6 or 7 pediatric trials of these drugs where regulators have allowed LCI to be a primary outcome in that age group, following on from efficacy studies in older patients. So very pleased with the way that's going. But I also mentioned about outside the lung and the fact that we're beginning in children to see some benefit in pancreas. What we've got here is study data from an ivacaftor study in children who were under the age of 5 at the time they started. The y-axis is fecal elastase 1, which is the best readout of pancreatic exocrine function. So the elastase that's produced in the pancreas, does it get out into the gut and pass into the stool? And for the vast majority of these children at the start of the trial, they had very low or even undetectable levels. But within the first 6 months of the trial, we see restoration of pancreatic function. This dotted line is the treatment line for giving pancreatic enzyme supplements. So if you're above this, you usually manage to get away without them. And we saw that a distinct proportion of these children managed to get above that line. And as we've come down in age groups, these children, the youngest were 2, as we've come down to 1 year, 6 months, 4 months, we find the proportion of babies being able to do this goes up. So clearly the pancreas is not irreversibly destroyed at birth. There is some potential for recovery, and this has sort of lifelong benefits in terms of dietary, nutrition, and quality of life. But there are also other complications that might have an impact, and this is CFTR-related diabetes, and these are the same registry data as I showed you earlier, where you can see there's potentially an impact on that over time. Diabetes is a real pain for people with CF. By adulthood, 1/3 to 50% of people have it. They, on top of everything else, they do have to inject insulin, and it has other health consequences in terms of being related to poorer pulmonary outcomes. So it would be great if we could achieve those benefits as well. So there are a couple of very big observational studies looking at all the sort of breadth of capturing benefit, both in the US with the TDN and in the UK and Ireland at the moment. And we're looking at quite a large range of outcome measures. So infections, microbiology, GI-related quality of life, endocrine, sputum and inflammatory markers. So really trying to gather in a real-world context quite how much benefit these agents can produce. So you can tell I'm an advocate. I think I've probably quite nicely outlined the upside of all this. We do need to talk about the downsides, and there are some. One of these is that people with cystic fibrosis were required to stay on all of their treatments for these trials. So we have seen the ability of the drugs to improve things in the context of all those other treatments. And as I said, it's not unusual for somebody to be spending at least 2 hours a day during their everyday treatment with their airway clearance and physiotherapy and all of their nebulizers, etc. So that burden of treatment remains because that's how we're using them at the moment. We're not telling people to give up on their other drugs. There are also some people who have side effects and can't tolerate the drugs at all. There are quite substantial drug-drug interactions, and there is a proportion of people with cystic fibrosis who have mutations that are just not suitable for these drugs, and they're missing out. And I think in the excitement and the enthusiasm with which we're greeting the new era, we really need to remember that group of patients because they're feeling even more left behind as time goes on. So onto the burden of treatment. This is quite a common list of the sorts of treatments that people with cystic fibrosis have to take every single day. And you can see that the development of them over time has been associated with a quite extraordinary improvement in life expectancy. If I'd have been born with CF, I wouldn't have probably made it to secondary school. But now people are living quite commonly into their 40s and 50s. But it is with this enormous burden of treatment, and that is one thing that people complain about a lot. There was recently a James Lind Alliance priority setting partnership conducted in the UK, run by a good colleague and friend of mine, Alan Smith in Nottingham. And the top priority that people said needed to be looked into for research was how could we simplify the treatment burden for people with cystic fibrosis. So that sort of call to arms has been heeded, and we have managed to get money through NIHR for a big multi-centre study led by Kevin Southern, actually, who's a paediatrician here in Liverpool, and a colleague of mine in London, Jane Davies, called CF Storm. And what's happening in this trial is that once patients are established on Kaftrio and they're stable on it, we're randomizing them to stop taking their inhaled mucolytic drugs. So if they're on Dornase alpha or if they're on hypertonic saline, they get randomized to stop both of those or to carry them on. And what we're trying to do is to assess whether or not it's safe to do that because they are deemed the most burdensome of treatments. And I very much hope that it will be because I think it'll make a big difference to people's lives. In terms of the common side effects and intolerances, the sort of regular day-to-day bread and butter of our clinic is that people can sometimes get disturbances in liver function. They do therefore need regular monitoring. It's part of the label. If they do get a big rise in liver function, they might respond to an interruption and tolerate getting back on the drug again. But there is a small minority who don't really ever tolerate it, and their livers are just a little bit too sensitive and they can't take the drugs. There's also a requirement, at least in pediatric population, to do ophthalmology monitoring based on the fact that in the preclinical toxicology studies of ivacaftor in early life animals, there were some lens opacities or cataracts seen. There's been very few reports in humans. There have been some, but we're not clear on many of those whether those lens opacities predated the introduction of the ivacaftor, and in general they don't affect visual acuity at all. So how important they are, I don't know, but there is monitoring in place for people, and that's a little bit burdensome. There are other common side effects which are usually mild or well tolerated, such as rashes. A lung purge is something that people describe very, very vividly when they're commenced on Kaftrio within the first 2 to 3 days, particularly adults who've got established lung disease and bronchiectasis. They'll start taking Kaftrio and they will experience more mucus and sputum production than they have ever encountered in their entire life. And a lot of it looks like really old, crusty plugs that's probably been down there for absolutely ages. And it's quite alarming when they first encounter that. So we do warn people they may encounter it and that it's actually a really good thing, because that's stuff that's better out than in. But it can be something that's reported as a bit disconcerting. And there's an area here where I really feel more work is needed. There are some case reports, an increasing number of case reports and short series appearing in the literature of people experiencing mood disturbance, either anxiety or depression, or even in some extremes suicidal ideation. And I think this is something that we very, very much need to look into, about whether it's a direct relationship to the pharmacology of the drug, or whether it's something else complex in the mood disturbances and depression and anxiety that are common in cystic fibrosis anyway. So something that we're spending a bit of time thinking about now. And then just briefly talking about the drug-drug interactions. This has been quite nicely reviewed, not particularly from a modulator point of view in this one, but from several other drugs that we use. But these modulators are substrates of CYP3A. And because of that, there's quite a lot of drugs that we use in cystic fibrosis which can pose problems in terms of DDIs and the requirement for dose adjustments. And we're really, really hindered by not having any monitoring ability for any of the modulators, which is commercially available or validated. And so there are dose adjustments. For example, it's very common that people need to go on an azole antifungal drug because, for example, they've got aspergillus. The dose reduction here is really very dramatic. So for ivacaftor, which would be twice daily, the reduction is to dose twice weekly. And I think we're concerned that some of those reductions are too big and that people are missing out on potential benefit of the modulator. You can see here also if somebody acquires an atypical mycobacterium and needs a combination of drugs that includes rifampicin, we're really supposed to actually stop the modulator. And that can be a major problem with people who are experiencing a flare-up of lung disease because of the infection anyway. So this is a major problem, and whether or not it would be possible for future drugs to avoid these sort of interactions, I'm not clever enough to know, because it may be that any of these agents are always going to have this metabolic pathway and always going to have this issue. But it certainly is something that clinicians are battling with and would be ameliorated, at least in part, if we could get therapeutic drug monitoring. So just sort of briefly in terms of wrapping up, are we done? It's all sounding pretty good. I strongly feel we're not done. We've still got a lot more work to do. Somebody who's got a chest CT like this has got established disease. No modulator is going to turn back the clock on that sort of bronchiectasis. We know that pulmonary exacerbations are reduced in number, they're not prevented, and we know that whilst chronic infection rates seem to be lower, it's not completely cleared. So this type of person is going to have an ongoing need for other treatments, and I think it's really important that within, for example, the European Clinical Trials Network, we do keep some attention on the more downstream or symptom-targeted drugs and make sure that those trials get adequately supported as well, because these treatments are going to be important for people. In terms of the newer agents that people are looking at, once daily dosing is something that could improve things. Could we ever avoid the need to take with a high-fat food? A lot of people don't want to immediately eat a bacon sandwich when they wake up in the morning, and that would be an advantage, as would the DDIs. There are big regional differences in availability related to cost, and so at the moment, as you can see, all the drugs I've talked about are from a single manufacturer, and that is going to continue to be a problem in that context. And then people with gene variants that are not modulator responsive really have nothing at the moment. And I just want to briefly talk about them as we close. So I've mentioned already, for the people who don't make any CFTR, there are options. They're in clinical trials. But there's a lot of people, as I mentioned at the beginning, with rare mutations. They may not be eligible for these drugs, not because they can't respond, but because nobody's ever tested whether they could respond, and we could never power a clinical study because there wouldn't be enough people with that mutation to be able to do that. But it is possible they would respond. And so there's a new approach that is being sort of postulated, or two new approaches really, called serotyping and theranostics, whereby patient samples, either airway or more commonly gut, are actually taken into the laboratory, grown up either in monolayers or into these organoids, and then exposed to various combinations of currently available drugs to see if they could actually have an impact. And there's a study at the moment going on across Europe doing exactly this, taking patients with 2 rare mutations, growing up their organoids, and then exposing them to a wide variety of currently available and experimental modulator drugs. Here's a very nice review of that field, which I think shows an awful lot of promise. And HIT-CF in Europe is the study that's doing that at the moment, and they're just about to start their first clinical study, actually allowing patients whose organoids did and didn't respond to these drugs access to a new drug through a drug trial. So here's where I'm going to finish, and this is the modulator landscape now. If we look at all people in the world with cystic fibrosis, if we'd have looked at this 10 years ago, there wouldn't have been any of these drugs available for any of them. So there's really been very, very fantastic progress in terms of the drugs that are available now. Ivacaftor was the first to come through. It's gone sequentially lower and lower in age groups so that we can now prescribe this after newborn screening to a 4-month-old baby. And I really hope that the majority of those are going to be able to avoid the majority of the consequences of CF during their lifetime. We don't yet have that data, and it's very important we collect it. Orkambi is available for children 2 years and above, and the tezacaftor-iva combination, which is Symkevi, is available for children 6 years above, both with 2 copies of 508 and also residual function. But this is where the biggest impact has been made within the last few years, and the triple is now licensed and available for children 6 years and above, and in England at least we can prescribe this to any child with either 1 or 2 copies of F508. So it doesn't matter what's on the other allele, and this is a really, really big group of patients. We mustn't forget them, but I think it is good to be able to celebrate the progress that has been made through this. And I just wanted on that note to really acknowledge the clinical trials networks, both the European Clinical Trial Network and the UK CTAP, as well as the TDN in the US, because I think it is the establishment and the harmonization of processes through those networks that has enabled the collaborations with industry and the testing of these drugs as rapidly and as effectively as we've actually been able to do them and support industry bringing these drugs to market. So thank you very much for your attention, and I hope that you're excited by that.
Jane, thank you for a brilliant talk. We have time for a couple of questions, and I'd like to start off. You showed a couple of slides with data sets collected in the UK and the US, particularly on disease progression, if I was following along correctly. And it looked to me that the magnitude of effect in the UK was a bit larger than in the US. And I wonder, A, is that a correct interpretation? And B, if so, is there any mechanistic understanding about why you might see a bigger effect in the UK population?
So I'm pretty certain that if my colleagues from the UK registry were in the audience, they'd kill me if I said there was a difference, because the study was not designed to look for differences between the two, and I don't think they were looked for. I know what you're talking about, and to the eye, it does look as though there might be a bit of a bigger effect. So I don't know the answer to your question, but I do know that when data sets have been looked at from the US and UK, there have been small incremental higher levels of various health outcomes in the US population. And we're very interested in looking into that and whether that is real in terms of health outcomes or whether it's something to do with population lung functions. But it may be that there are differences in populations, and quite why that would translate into bigger improvements in one than the other, I don't know. And whether that is a real bigger anyway, I don't know. But I know what you mean. That study wasn't designed to answer that question.
Thank you. Question number 1?
Yes.
Yeah?
Martin Michel, Mainz, Germany. I know preciously little about CF, so my question may be somewhat naive. If the PD phenotype of a changed chloride level in the skin test is so robust, and you have so many rare mutations which are just too rare to really run a trial, and the drug isn't that super toxic, isn't it a pragmatic approach to put those kids on the drug for 2 weeks, see whether their chloride test improves, and if yes, keep going, and if not, take them off?
Man after my own heart. I think you've absolutely hit the nail on the head, and one of the references that I used earlier on was a sort of consensus from a task force within the ECFS where we said exactly this, not just even in that context, but as a rapid readout of the impact of a drug and the ability of a drug to work. And I think it is something that's very, very important. There is actually precedent for that in certain countries. I think I'm right in saying the Netherlands, they have done some in vitro cell testing followed by an N of 1 study in a small number of patients, and they succeeded in getting approval for funding for those patients to carry on having the drug. There have been conversations with other regulatory agencies that I'm aware of which haven't met quite so favourably with that. But I really do hope that it's something that might be considered in the future. One of the big caveats to all that, and which I didn't have time to go into, but is very important, I think, particularly in the current era, is that there is a very high proportion amongst people with rare mutations who are non-Caucasian and who come from different ethnic populations and who are actually in countries where these drugs are not yet available for the majority of patients either. And so I think we're very, very keen to try and make sure that whatever we do in the developed countries which have bigger access to the drugs can actually ripple out into those countries as well. I think it's something that we really try and focus on in terms of ensuring equity. But I like your idea. And you say you don't know much about CF. I hope you know a little more than you did when you came in the room. Otherwise, I could just get back on the train and go home.
Number 2.
Thank you for this talk. I really enjoyed it. Question for you. One of the complications usually is a decline in kidney function, either because of the disease or the nephrotoxic drugs that we use. Have you seen an improvement or a lack of decline in kidney function after the use of the modulators?
So I think, as far as I know, and I'm not a renal expert at all, but I think that most body of opinion would be that it is man-made, the kidney problem. It's not genetic. Although there is CFTR in the kidney doesn't show disease in and of itself. It seems to be the way we use drugs, particularly aminoglycosides, which causes the problem. There will be being less aminoglycosides being used since these drugs have been available, but I've never seen a study where somebody has yet looked at the consequences of those and said, and that's got an impact on these outcomes. I suspect it would take longer than the period of time we've had with these drugs available to be able to see that, but I think it is exactly the sort of collateral benefit that we might expect from using these drugs more widely, is that people won't be using aminoglycoside IV half as much.
Thank you.
Thank you very much. I'd like to thank Jane again for an outstanding presentation. Thank you. I'd also like to call Professor Cherry Wainright to the stage for closing remarks and prize giving. Thank you.
Thanks for an absolutely wonderful talk. I've certainly learned an awful lot more about cystic fibrosis than I started with. Very inspiring, thank you. End of day 2. In any given year, attending a BPS annual meeting is a really informative, inspiring, and exciting experience. It's always really special to see members right across the field of pharmacology and therapeutics come together to share their latest research findings and to catch up with friends. This year, of course, has been particularly poignant because we're holding the meeting in person for the first time since COVID-19 swept across the globe. Over the past 2.5 years, the pharmacology community, along with our colleagues right across the scientific spectrum, have adapted and responded to challenges posed by the pandemic with both diligence and courage. So I'm delighted that we've been able to meet face-to-face again to celebrate our achievements and to discover the latest developments in the field. When it comes to making the connections that can guide you on your career, nothing beats real-life interaction. And it's been actually wonderful to see this taking place over the last 2 days here at Pharmacology 2022. And this is particularly important for our early career members. So if any of you in the audience donated or chose to give a ticket this year to an early career researcher to attend the conference, we give you great thanks. You've directly, through doing this, you've directly supported and encouraged somebody at the very beginning of their pharmacology journey. The BPS can facilitate that all-important contact between pharmacologists from different areas of interest, different career stages, and different places around the world. It's actually one of the biggest benefits of membership of the BPS. So if you've joined us this week as a guest, then I encourage you to sign up and become part of our thriving community. Meetings don't just happen, and so there's a lot of people that I would like to thank that have been involved in bringing Pharmacology 2022 to life. The meetings committee, a highly important group of people who help to set the program of symposia and do the rigorous refereeing process along with our referees for the abstracts that are submitted for communications. The BPS staff team, of course, and of course our speakers and chairs. But one person I would really like to give a special mention to is our events coordinator, Bonnie Rayner, who's actually managed her first annual pharmacology meeting with great aplomb and has done a fantastic job. So well done, Bonnie, and thank you very much for your help and support. I'd also like to thank our Pharmacology 2022 partners, in particular this year's gold partners, BMG Labtech Limited, who we thank for their continued support, and we hope to collaborate with you again in the future. Finally, before I move on to the prize giving, I would like to thank you, the delegates, for joining us. I hope you've enjoyed the meeting as much as I have. And while the bad news is that there will not be an annual meeting of the BPS in 2023, the good news is that is because we are hosting the World Congress of Pharmacology in Glasgow in July next year, and I look forward to seeing all of you then. And so I'd like to now move on to giving the prizes, and I'll just go and get my list. Before I announce the winners of the abstract prizes, I have the pleasure of presenting a certificate for the Society's Diploma in Advanced Pharmacology. Graduating this year is Dr. Patrick Okechukwu. Is he here? Okay, so moving on to the prizes from day one. The first prize is the Dom Spina Prize for Experimental Design and Analysis, and this goes to Helen Collins. I'm struggling to see, so I'm not sure if anybody's making their way along. No. Okay. Helen here, no? Okay, the next prize, Early Career Best Oral Communication Prize, goes to Paul Thompson. There are two early career poster prizes. I'll call both names at the same time, Joshua Gardner and Adam Jameson. Late-breaking poster prize goes to Rebecca Annels. The undergraduate poster prize, Jolanta Carrier. And the last prize for day one, the Flash Poster Presentation Prize, Robin Key. Oh, here we go. The prize is for day two. The Early Career Oral Communication Prize goes to Andrew Lambas. It's a very big hall to have to make your way across. The Early Career Poster Prize goes to Anna Fortuny Gomez. Okay. Late Breaking Poster Prize goes to Elizabeth Adeyeye. The Clinical Oral Prize goes to Nora Abahimid. The Clinical Poster Prize, Philip Drennan. The Education Oral Prize goes to Patience Nimusima. Oh, here she comes. The Education Poster Prize to Cohen Weigman. The International Oral Prize, Igor Radanovich. The International Poster Prize, Marzia Pendino. The Undergraduate Poster Prize goes to Cameron Smith. And the final prize is the Flash Poster Presentation Prize for today, Maha Abdullah. Well, that concludes the prize announcements for this year. I would just like to thank all of the judges who were involved. It's quite a detailed job to go around all the posters and listen to all the communications, so I thoroughly pass on my great thanks to them. So all it is left for me to say is to thank all of you for coming. Have a safe journey home, and we look forward to seeing you in Glasgow next year. And that is the conference now officially closed. Thank you very much.